Hello, I'm Mary Ann Mansour, clinical specialist for Pulmodine. I've been a registered respiratory therapist for over 30 years practicing in the Chicagoland area. Today I am going to show you the Blom Tracheostomy Tube and its 4 unique inner cannulas. Standard cannula, subglottic suctioning cannula, speech cannula, and our low profile valve, which is used for spontaneously breathing non-ventilated patients. Here we have the Blom Tracheostomy Tube in use with the LTV1000. I will be demonstrating how the Blom Tracheostomy Tube interacts with the LTV1000. This is the Blum standard cannula in use with the LTV1000. My ventilator settings are SIMV of 12, 600, and PEEP of 5. Insertion of the subglottic suctioning cannula. You will now hear an audible click indicating the cannula is now secured to the Blum outer cannula. Now we are using the Blum subglottic suctioning inner cannula. Our ventilator settings are the same, SIMV of 12, tidal volume of 600, PEEP of 5. As you can see, our peak inspiratory pressure remains the same at 16. Now we're using our speech cannula. Again, our settings are SIMV of 12, tidal volume of 600, PEEP of 5. As you can see, our peak inspiratory pressure has gone up to around 24. The reason for that is the narrowing at the bottom of the speech cannula where the flap valve is. You will only see the increase in pressure in the cannula itself and not in the patient's lungs. During the use of the Blum speech cannula, the exhaled air is redirected through the fenestration to the upper airway to produce speech. No exhaled air is being returned to the ventilator for monitoring, causing the low minute volume alarm to sound. Disabling the alarm is not advised. The EVR is a small bellows device that prevents nuisance alarms, which can occur when the speech cannula is in use. In order to prevent nuisance alarms, we connect the EVR in line at the Y where the exhale tidal volume is measured. The EVR works in conjunction with the compliance of the ventilator circuit to return a small volume of air to the ventilator during exhalation. On the LTV1000, you want to put your EVR at the Y, between the Y and the patient, where the ventilator measures exhale tidal volume. Then you want to turn your low exhaled minute volume off, and you will use your low pressure alarm as your disconnect. When using the speech cannula, we are able to maintain our PEEP level. As you can see, our PEEP is set at 4 centimeters of water pressure, and our baseline is coming back down to 4 centimeters of water pressure. We do not recommend using the speech cannula on patients requiring higher than 10 centimeters of water pressure. Remember, when using the speech cannula, either active or passive humidification can be used. When using passive humidification like an HME, be aware that no heat or moisture is going to be exchanged while the speech cannula is in use. This is because all of the air is being redirected out of the upper airway rather than back through the HME. When exhalation is incomplete, a percentage of inspired air remains trapped within the lungs, causing a condition called autopeep. If this condition becomes severe, pulmonary and cardiac issues can develop rapidly. A continuous high pressure alarm may indicate auto PEEP or air trapping. If this scenario should occur, the speech cannula should be removed immediately and replaced with a standard cannula. Prior to reinsertion of the speech cannula, verify the patient has a patent upper airway and consider repositioning the patient. Also, suctioning the patient both above and below the cuff is recommended.